Welcome to the deep dive. Today we are getting into something that affects millions of lives, the struggle for control. We're looking at the brain science behind impulsivity, compulsivity, and addiction.
And our sources for this are straight from a core text on psychopharmacology. The mission today is to really map this out from basic definitions to the brain circuits involved, and then to how different drugs actually work on that wiring.
Okay, so let's start with that first absolutely critical distinction.
Yeah.
Impulsivity and compulsivity. They're often used interchangeably, but they're not the same thing at all, are they?
Not at all. In fact, you could almost see them as opposites, even though they both feel like a lack of control.
Opposites how?
Well, impulsivity is the inability to stop initiating an action. It's that rapid, unplanned, let's do this now kind of behavior without really thinking through the consequences. You're chasing an immediate reward.
So failing to hit the brakes.
Exactly. Whereas compulsivity is the inability to terminate an action that's already happening. It's repetitive. It's stereotypical. Think of someone endlessly checking a lock.
And that's usually done to avoid something bad, not to feel good.
Precisely. It's driven by anxiety reduction, not pleasure seeking.
And the sources have this really powerful analogy for how addiction fits in. It's described as a twisted form of learning, like a Pavlovian dog.
It's a perfect analogy. A habit is essentially a stimulus-response action that gets stamped into your brain. It becomes automatic. And with addiction, the drug-seeking behavior becomes that kind of mindless, conditioned habit.
So it's not even about the drug anymore. It's about the cues. The lighter, the room, the time of day.
Right. The brain learns to react to those cues automatically, just like the dog salivating at the bell, whether or not there's any food.
Yeah.
The habit takes over.
Which leads us to the fundamental brain problem here. The brain just has a really hard time saying no. Where is that failure happening?
It's happening in these massive feedback loops between the cortex, your thinking brain, and the deeper structures, the striatum.
Huh.
We have these two competing bottom-up circuits that are basically screaming for attention.
Let's take the first one, the one for impulsivity. The sources call it the ventral loop.
Right. Think of this as your reward and motivation engine. It's centered in the ventral striatum. You might know it as the nucleus accumbens, and it's all about action and outcome.
So when that's overactive, you get the risk-taking, the I want it now behavior.
That's the one. It's constantly sending these go, go, go signals up to your prefrontal cortex.
And the other circuit for compulsivity is the dorsal loop, the habit system.
Yes, and this one is centered in the dorsal striatum. This part of the brain is more involved in automatic motor programs. If the ventral loop is about the thrill of the reward, the dorsal loop is about mindless repetition.
Okay, so this has to be the key point then. The sources talk about a vicious spiral. This is about control shifting from one system to the other.
This is the absolute core of how an addiction develops. An impulsive act, trying a drug for the first time, starts in that ventral reward-seeking system. It feels good, but with repetition.
The control migrates.
The control migrates. It moves dorsally into the habit system. And this is the tragedy of it. The person is no longer even chasing that initial high. They're just serving the habit. The action has become completely disconnected from the original goal.
And the goal of treatment, then, would be to somehow reverse that migration, to push control back to the ventral system, or better yet, to the prefrontal cortex.
That's the theory. But before we get to treatment, we have to talk about the fuel for this whole engine. Dopamine, the mesolimbic dopamine pathway.
Right, the so-called final common pathway for reward.
For decades, that's how we've seen it. This highway from a deep brain area called the VTA up to the nucleus accumbens. Now, natural rewards, a great meal, seeing a friend, they tickle this system.
They use the brain's own pharmacy.
Exactly. Our own endorphins, our own endocannabinoids. But drugs of abuse, they're a hostile takeover. They bypass the natural process entirely.
And the dopamine release isn't just a little stronger, it's what? An explosion.
An explosion. It's faster, higher, and much more intense than anything the brain can produce on its own. And that intensity is what rewires the circuits so quickly and so damagingly.
Which brings us to the paradox. Once you're addicted, the dopamine neurons, they stop caring about the drug itself.
They stop responding to it. The system adapts. Instead, it's the cues we talked about that trigger the dopamine release.
The anticipation.
The anticipation. Seeing the syringe, walking into the bar, that's what drives the craving. It's a compulsive, cue-driven hunt, and the pleasure of the drug has become almost an afterthought.
Let's make this concrete. Let's talk about stimulants, cocaine, amphetamines. What are they doing at the synapse?
They're essentially blocking the cleanup crew. There's a protein called the dopamine transporter, or D8T, that sucks dopamine back up into the neuron after it's been released. Stimulants physically block that transporter.
So dopamine just stays in the synapse, hammering on the receptors over and over.
For much longer and at much higher concentrations, and the speed is everything here.
Which is why smoking or injecting is so much more addictive than taking a pill.
Absolutely. The faster that drug occupies the transporters in the brain, the bigger that phasic dopamine spike is, and the more reinforcing it becomes. But chronic use leads to this state of burnout.
The system just gets exhausted.
Depleted, the neurons can even degenerate, and the person is left with this profound anhedonia and inability to feel pleasure from anything. And the tragic part is, we still don't have a single FDA-approved medication for stimulant addiction.
Wow. Okay, let's move to nicotine. Probably the single most addictive substance, and rates are incredibly high in people with other psychiatric conditions.
And its mechanism is incredibly precise. It targets a specific receptor subtype, the alpha-4-beta-2 nicotinic acetylcholine receptor, which sits right on the dopamine neurons in the VTA.
And the sources describe this almost perfectly engineered cycle of craving.
It's time to the act of smoking a cigarette. When you smoke, nicotine binds, you get a dopamine release. But then over the course of that cigarette, the receptors desensitize, they shut down.
They go offline.
They go offline. But then they start to resensitize a short time later. And it's that process of waking back up that generates the intense craving for the next one.
And it gets worse, because the brain actually builds more of these receptors over time.
It does. It's called upregulation. So a chronic smoker has a brain that's just studded with these extra hypersensitive nicotine receptors, making the withdrawal and craving that much more powerful.
So treatment, then, is about managing that system. Nicotine replacement patches. Gum gives you the nicotine without the rapid, rewarding spike.
Slow and steady. It keeps the receptors occupied without providing the big rush. But the really clever tool we have now is varenicline.
Which is a partial agonist. What does that mean in simple terms?
Think of it like a dimmer switch instead of an on-off switch. It binds to that alpha-4-beta-2 receptor, but it only stimulates it a little bit.
Just enough to take the edge off the withdrawal craving.
Exactly. But here's the brilliant part. Because it's sitting on the receptor, it's also blocking it. So if the person slips up and has a cigarette,
The nicotine has nowhere to go.
the nicotine can't bind effectively. It can't produce that massive dopamine surge. The reward is extinguished.
It's a pharmacological extinction tool. And what about bupropion?
Bupropion is different. It's an antidepressant that also weakly boosts dopamine and norepinephrine. So during that tough early abstinence phase, it sort of props up the dopamine system, making the cravings a little less brutal.
Let's shift to alcohol.
Ah.
It feels more widespread.
Mhm.
What's its main action?
Alcohol is kind of a messy drug pharmacologically, but its main effect is twofold. It boosts inhibition by enhancing the effect of the neurotransmitter GABA, and it reduces excitation by blocking glutamate.
So it calms the brain down. But where does the high come from?
The high, the reinforcing part, seems to be mediated by the brain's own opioid system. Alcohol triggers the release of our endogenous opioids like beta-endorphin, and that's what stimulates the dopamine release in the reward pathway.
Ah, so that's a target for treatment. Drugs like naltrexone.
Exactly. Naltrexone is a mu-opioid antagonist. It blocks those receptors. So if you drink on naltrexone, you might still feel the sedative effects of alcohol, but you don't get that euphoric high. It takes the fun out of it, essentially.
And what about something like a camprosate? That works on withdrawal, right?
Yes, it's a really interesting one. After chronic alcohol use, the brain is in a hyper-excitable state to compensate. Too much glutamate, not enough GABA. It's why withdrawal can be so dangerous. A camprosate seems to normalize that glutamate system, calming everything down and reducing the awful symptoms of protracted withdrawal.
Okay, on to opioids. This is obviously a huge crisis. Prescription pills, fentanyl.
And the defining features here are incredibly rapid tolerance and a horrific withdrawal syndrome. The dysphoria, the agitation, the sickness. It's so awful that avoiding it becomes the main motivation. The user isn't chasing a high anymore. They're just running from being sick.
And our main strategy is substitution therapy.
For the most part, yes. We use a full agonist like methadone or a partial agonist like buprenorphine. They occupy the opioid receptors, they prevent withdrawal, but they do it in a slow, stable way that doesn't produce the same intense euphoria.
Buprenorphine is often combined with naloxone, right, to prevent misuse.
Right. If you take the combination pill as directed, the naloxone isn't absorbed. But if you try to crush and inject it to get a rush, the naloxone becomes active and it immediately blocks the opioid receptors, precipitating withdrawal. It's a very clever deterrent.
And we also have long-acting injectable naltrexone for opioids, too.
Yes, which is a fantastic option for some. It blocks the receptors for a full month. It reduces the treatment burden to just one decision, one appointment every month instead of a daily battle of willpower.
Let's touch on cannabis. This involves a whole different system in the brain.
A totally unique system, the endocannabinoids. This is the brain's own cannabis, and what's wild is that they work backwards.
What do you mean backwards?
Most neurotransmitters go from neuron A to neuron B. Endocannabinoids are released from neuron B and travel backward to neuron A to tell it to quiet down. It's a retrograde signaling system.
And THC, the active ingredient in cannabis, hijacks that system.
It does. It binds to the CB1 receptors. The concern, especially with modern high-THC, low-CBD strains, is the risk of anxiety, psychosis, and what's often called an amotivational syndrome.
Right, a quick run through the last group. Hallucinogens like LSD, empathogens like MDMA, and dissociatives like ketamine.
Very briefly, yes. Hallucinogens are primarily 5-HT2A receptor agonists. MDMA, or Molly, causes a massive flood of serotonin, and dissociatives like ketamine are NMDA receptor antagonists.
And ketamine in particular is being studied for all sorts of things, including addiction.
It is. The idea is that it might help to disrupt those deeply ingrained rigid neural circuits and promote new learning.
Which brings us back to what feels like the most revolutionary idea in the sources, this concept of pharmacological extinction. The phrase they use is abuse your way to abstinence. It sounds completely backward.
It does, but it makes perfect sense if you view addiction as a learned habit. How do you unlearn something? You have to break the connection between the action and the expected reward.
So you take a drug like naltrexone, which blocks the reward, and then use the substance of abuse.
And the expected high doesn't come. The brain expects reward A, but it gets nothing. And if you repeat that,
The brain unlearns the connection, the habit loop is broken.
the habit is extinguished. The repeated failure to get the reward forces that behavioral control out of the mindless compulsive dorsal habit system and back into the realm of conscious voluntary choice.
And this framework,
Yeah.
it doesn't just apply to drugs. It fits something like OCD perfectly.
It's a perfect parallel. The compulsions, the checking, the cleaning are habits triggered by a stimulus to reduce anxiety. The most effective therapy, exposure and response prevention, is literally a form of behavioral extinction. You expose the person to the trigger, but you prevent them from performing the compulsion. You break the loop.
And the sources suggest this actually reverses the abnormal brain wiring. We even see this with binge eating disorder and the use of a stimulant.
Exactly. Lisdexamfetamine isn't just an appetite suppressant. The thinking is that it promotes neuroplasticity in the striatum, helping to restore voluntary control over these ingrained compulsive eating behaviors. It's all part of the same spectrum.
So at the end of the day, what is the single biggest takeaway from all of this for you?
That the core problem across all these disorders, from cocaine addiction to impulsive violence to OCD, is it's a failure to say no. It's a biological problem of dysregulated control. And the real tragedy of addiction is watching control migrate from a system that seeks goals to one that just mindlessly runs a program.
And if addiction's really a form of molecular memory, a habit learned so deeply it might last a lifetime,
Yeah.
then just telling someone to stop isn't enough.
It's not. The future, it seems, isn't just about preventing relapse, but about actively unlearning the addiction itself.
Which leaves us with a really provocative final thought. If the most effective treatments might involve forcing the brain to fail repeatedly at getting what it craves, what does that say about the nature of recovery? It's not just about avoidance. It might be about confrontation.
A kind of pharmacologically assisted confrontation, yes. It's a complicated and fascinating new frontier.
It certainly is. This has been an incredibly insightful tour of the brain's struggle for control. Thank you so much for guiding us through it. And to all of you, thank you for joining us for this deep dive.